the first question is not that one. Well, I guess the first question is about sequels. So this is the interim final rule. It's a sequel, and so there could be a prize in it for anyone who can convince us that they think a sequel is better than the original. Katie and I are going to be the total and arbitrary judges on this. People who listen to Monitor Monday know already, so I'm going to take this one off the table because I played the Empire Strikes Back theme on Monday and said I think that's a candidate. So I'm going to apologize for everyone who thinks that's it. That one's off the table. Katie, do you have any comments you want to offer?
I think also off the table, although probably very hotly debated during this quarantine, is whether Frozen 2 is better than Frozen 1. Just so you know, we're house divided here. I think 2 of the 4 of us think Frozen 1 is better, and my daughter and husband think Frozen 2 is better. So I guess that one's off the table as well. Well,
that leads very nicely into this next question because you do have young children. I've got 2 teenagers that we're quarantined at home with, and so I think this cartoon, Gary Larson captures many things well, and quarantine is one of them. How's quarantine going for you? Okay, crybaby, you want the last soda? Well, let me get it ready for you. So how's your quarantine going, Katie?
I can't complain. We're all home, and we don't have to leave, so that's very lucky for us. So that puts things in perspective. Although it is, it's a lot of togetherness, and the cartoon is quite apt, David, because in my house, the most frequently asked question by my 4- and 6-year-old is, "Can I have a snack?" So I am often preparing food for others.
Well, if we get to this whole webinar without them popping in, you are a better parent than I. I'm just going to say that.
Or they're worse because they are locked somewhere. I don't know.
So, all right, that's enough of our personal background, although I'm sure it'll creep up. How did we get here? So the original public health emergency, and Katie's going to go through some acronyms in a minute, but that's the PHE, and you will see PHE a lot for public health emergency, started way back January 31st, 2020, at a time when a bunch of people were saying this wasn't a big deal. I will acknowledge I was buying a lot of peanut butter back then, but I was being mocked for it by my family. And so that's when the public health emergency starts. Then the laws start coming out. And the first one, which has a long name, the Corona Preparedness and Response and Supplemental Appropriations Act, was March 6th. It seems like eons ago. A week later, the president declares a national emergency. Then, in something which I think is pretty weird, just 12 days after our first legislation, we got additional legislation, the Families First Coronavirus Act. That's got some more stuff. And then what we talk about probably the most, people hear about the CARES Act, but it's just worth remembering there are 3 different laws. So the CARES Act didn't come out until March. Then we get the first IFC, and we made fun of this last time. We're going to kind of always make fun of this. It, of course, stands for Interim Final Rule. Don't ask, because we can't explain it. So we all learned about it on March 30th. Apparently the 30th is the day these things come out. And the way it works is there's a version that's released on the internet, which is kind of called the pre-publication version. It's double-spaced, and then ultimately it appears in the Federal Register after some period of time. The last one, it was a week. So on April 6th, it appeared in the Federal Register. The most recent one, to the best of my knowledge, has not yet appeared in the Federal Register. I guess it may have this morning. I did not check. But so that's our background. I am a fan of New Yorker cartoons. This one is the opposite of where we're at. He thought the creature seemed more conciliatory as of late. He was sadly mistaken. Actually, though, I have to say, and I don't know if you agree with me on this, Katie, I think CMS did a marvelous job. I think the sequel is better than the original here. They've cleaned more stuff up, and I'm impressed.
I think that's right. I think maybe the virus is the dinosaur and not CMS.
Oh, yeah. That's actually, I hadn't thought of that. That's kind of deep but depressing.
Mm-hmm.
I hate it when you're right and make me sadder. Okay, so now that I'm sort of tearing up, let's do some general thoughts. So most of what we're going to talk about today and most of the changes only apply during the emergency, but a lot of them are retroactive. And this gets kind of confusing in a few ways. First, some things do say that they apply during the public health emergency, and that in theory is back to January 31st. For most of what we're going to talk about, March 1st is the default. Then this is a confusing point. So we were going through the slides, and Katie said, David, where's the slide about telehealth for physical therapists, occupational therapists, and speech language pathologists? And I'm like, that's a really good question, because we did not at that point have the slide. It has since been added in, but we didn't have it there. And the reason we didn't have it there, other than I'm sometimes careless, is that we were using as the source documents for this the interim final rule and the waiver documents. And in fact, that piece of information came out in a press release, which is really a weird way to get a regulatory guidance. And I find it extra weird because for about 3 weeks now, Katie and I have been saying, hey, we think that those therapy services can be billed incident to. And we had a rationale for that. We sent that rationale to CMS. And we agreed that in the hospital there wasn't a clear legal framework. But CMS was saying, we think legally we would love to let telehealth be done by PT, OT, and speech, but we can't. Well, that was their position for about 3 weeks, and then it changed, but no law changed. And they changed it in a press release. So could they have done it 3 weeks ago? I guess they could. But that highlights the weirdness of where we're at. I'm glad they did it. I think it's the right thing, but it's not regulatorily normal. Then a bunch of stuff. Yeah, go ahead.
Oh, sorry. I was just going to say that the other thing that's hard about this is that the CMS website isn't super intuitive with respect to what the releases are and what the linked items are. And so you can certainly find the final rules, but the waivers are often buried in sort of FAQ documents. So if you're looking for something and can't find it, you can always reach out to us and we can try to pin it down for you. But I will admit that my ability to navigate the CMS website on this stuff is elusive.
And in that vein, it is important to remember, I was working with Ron Hirsch at one point, and we had two different things on our screen, and we were trying to figure out why. And the reason why was you need to sometimes get rid of your cookies, because otherwise you will look at a cached version of the page, and you may not see the most recent version of things from CMS. So that's just another little weird trick that's out there. So I'm going to make this point on a couple of slides, but this is and those of you who are Monitor Monday listeners, you can ignore my segment Monday because this is going to be the thrust of it. I am amazed at how many times people have asked questions that I would argue they don't need to. You don't always need detail. You know, if in America, if there isn't a rule saying you can't do something, you can probably do it. And so a lot of people don't like ambiguity. And so they want to say, well, you know, can we do this or can we do that? You didn't say whether we could do this. That's the wrong question to ask. If they haven't prohibited you from doing something, you can do it. And that was encapsulated really well last week when one of the CMS folks, when responding to a call during office hours, said, our non-specificity provides the flexibility you are looking for, which sounds very Star Warsian to me. But what he's really saying is, stop asking. It's okay to do stuff and take your chance. So we'll come back to that, but embrace your ambiguity. I don't mean don't ask your lawyer a question, right? You might want to call Katie or me or one of your other, or call your counsel with a question. But if you can't get to certainty, it's often better to live in that ambiguity as opposed to asking the government. And I will take as a great example of that the physical therapy via telehealth, where we would tell you you could do it. And if you asked the government, you got to know. But I would feel 100% comfortable having defended you on that one. So just don't ask sometimes. So Katie, there's so many acronyms. Help.
Sure. I already thought of one that is in this presentation that isn't on our slide, but we've tried to put most of them on here. And if we if we forget one, just come back and chat us or send us a note. Hopefully a lot of these are recognizable, but PHE is certainly one we use a lot, the public health emergency, which did technically start for CMS purposes on January 31. Is that right, David?
Yep.
So just have a couple slides here with our acronyms. The one that isn't on here is LTC, long-term care facilities, that I can think of right now.
All right. And so for people who are listening, we're going to speak these, so it really only matters if you're looking at the slides. All right. So just a real couple of quick points on Stark. So I almost missed this, but last week, CMS put out a little explanatory document. And I'm not going to talk about it a lot because I didn't think it said a whole heck of a lot. But there's a little bit more guidance, and this is just a quick reminder. There are a bunch of Stark waivers. It's not universal. It isn't that Stark does not apply at all. It's just there are a bunch of situations in which you, for example, don't have to follow fair market value in a lease, right? You can do below market loans and the like, and so it's going to be possible for hospitals to help struggling physician clinics, although right now hospitals are struggling too. Here's another potential little prize question. If you took out the comma and you were to ask, don't ask me why. So there's the Billy Joel version, which I also did on Monitor Monday, but there's another don't ask me why. Who sings it? I'll bet there's more than one, but I've got one with platinum blonde hair in mind. So the don't ask me is just reinforcing the idea of when you ask the government a question. Because as part of its Stark guidance, CMS said that some people were asking, could you repay a loan in kind instead of in cash? And their response was, nothing in the rules requires a payment of cash. And what they were really saying, again, was let the ambiguity be your friend. And so that's a theme we're going to keep coming to. Don't ask the MAC a question. If you can't find a rule, you don't generally need to ask the MAC. They might give you an answer you don't like. And if you're going to be in an ambiguous situation, you're way better off in an ambiguous situation where you haven't asked the government and gotten the answer you do not want. All right. And so that's just my advice on how to approach this. So Katie, school us on home health value-based purchasing.
All right. So I was not able to keep my children out of the room, so we'll see how this goes. So the home health value-based purchasing, this is an FYI for folks out there who are in the midst of reporting. There are 9 states in which all of the home health agencies are required to participate in a value-based program. And basically what the interim final rule is saying is that for everyone else in the country who's a home health agency, those people are also participating in the quality reporting program. And CMS is saying in this interim final rule that basically we're going to make it easier for the value-based purchasing folks, and those people, to the extent they are reporting information that's the same as what they would be reporting in the QRP program, you can do it in the same way, the same time. They're going to streamline all of that. So you don't have to report the same information in 2 different ways and 2 different times. So if you want more sort of insight to go more in depth on that, we can dive in, but that's an FYI. If you're in these programs, you can be doing that in a more aligned way. And then they're also saying, look, any exceptions or extensions that we are going to grant for the QRP people, which is the whole country, those are also going to be granted for the value-based purchasing folks. So again, trying to make this easier. And then also the value-based purchasing folks are not going to need to be reporting any new measures for the submission periods that are ending April and July 2020. So that stuff you would need to be collecting now. You don't have to report those new measures. Those are being waived for now. All right. So one thing we've seen as the interim final rules have come out and as CMS has sort of adapted and flexed to this public health issue is they've been loosening restrictions on scope of practice for Medicare purposes. And that's really super helpful. You do have to remember that even though CMS may be loosening restrictions on scope of practice that were typically there pre-pandemic, the state law is still going to apply. The state law requirements vary by state, obviously, 50 different states for all these practitioners, and there may still be, restrictions on what different practitioners can do. And so those are still going to apply even for Medicare purposes. So you will see that the recordings always, or that the regulations are always saying, look, we might be loosening the scope of practice restriction for Medicare, but it's not going to work if your state law doesn't allow it. So one example that's super welcome, I think, that's going to help with a lot of the drive-up testing sites that are going to be emerging as we continue through this pandemic, is some loosened restrictions on supervision of diagnostic tests and ordering of diagnostic tests. So many of you are like,
Katie, I'm going to chime in. I want to just interrupt for a second because I just want to say one of the cool things about actually reading the interim final rule is they often give history and they explain how things have come to be. And so like if you're a new healthcare lawyer or something, you can often find background. Well, as part of their background on this, there was a statement that, of course, you're going to want to follow 42 CFR section symbol 41075. And I thought, as I saw that cite, I've never heard of 41075. And so it was a humbling moment for me to see the of course, followed by something I knew absolutely nothing about despite having done this for 27 years. And I mention it for a couple of reasons. One is don't feel bad if that happens to you, and maybe feel really proud if it doesn't happen to you. And then also to just mention, like this has happened to us several times in our career. Once it happened with Katie and I on a portable x-ray question where CMS had this obscure regulation that portable x-rays could only be ordered by a doctor. And they use that to assert nurse practitioners couldn't order portable x-rays, which we think is totally wrong, but it was buried in this rule from 1965. So I just wanted to say on this, I think Katie was smarter than I as I read that and went, "Ugh, okay, back to you, Katie."
Thank you, and thank you for that respite so I could extract a 6-year-old from my home office. So the diagnostic test rule 41032, as many of you know, has supervision requirements for diagnostic tests. And typically, pre-pandemic, pre-public health emergency, only physicians could supervise diagnostic tests. So we're talking about supervising, we're talking about those 3 levels of supervision, general, direct, and personal. Only physicians could supervise those, even though other types of practitioners, nurse practitioners, clinical nurse specialists, PAs, and certified nurse midwives could order, but they couldn't supervise. So what CMS has done back to March 1 is to say that those other types of practitioners can also supervise the test, again, if the state law allows it. So that's nice. The other thing that has happened with respect to the 41032 is that, again, pre-pandemic, 41032 said that a diagnostic test, in order to be paid by Medicare, could only be ordered by the physician or the practitioner who was treating the patient. And that really poses some issues, as I discovered last week in working with some clients on getting some drive-up testing sites going, because someone who drives up to a testing site hasn't necessarily had their treating physician or treating practitioner order the test, but they still should probably get the test. So luckily, CMS came out in this interim final rule saying that during the public health emergency, both COVID-19 tests and then some other diagnostic tests that are related to ruling out COVID-19 or diagnosing COVID-19 will be covered when they're ordered by any healthcare professional who can do that under state law, not just the treating practitioner. So in order to know what tests are on that list of the flexibility of it not just being the treating practitioner ordering, CMS is going to publish a list of tests. It's going to have like the influenza tests and a couple other respiratory virus tests that are typically used to when trying to figure out if someone has COVID-19. So watch for that list. But this is really helpful for people trying to set up drive-up testing in particular. Another additional change is with respect to opioid treatment programs. In the first IFC a few weeks ago, CMS said that therapy and counseling portions of that weekly bundle of services that OTPs furnish could be furnished not just by telehealth, but actually by audio-only telephones. This current final rule says that they're additionally going to permit OTPs to do the periodic assessment services, which I believe is required to sort of periodically assess what sort of services are needed to be furnished by the OTP. That's a G2077 code. That is added to the list of the types of services that can be provided by telehealth. They're saying is the gold standard. But if the person being treated doesn't have access to the AV technology, it could be done by audio only if whoever's doing it thinks that's still clinically appropriate.
Okay. We're going to have segues a lot, and here's a total change in topics to therapy student documentation. So last year's fee schedule did something which CMS thought was kind. We thought actually was unkind, which I'll explain in a minute. So last year, they allowed physician assistants, nurse practitioners, clinical nurse specialists, midwives, and CRNAs to review rather than redocument information. And so now they're saying that during this public health information, let's try that again, this public health emergency, anyone who's got an enumerated benefit under Medicare can review and sign, and they don't have to redocument. And the reason this kind of causes us to grate, if you've been a long-time webinar listener, you will know we've said a couple of things for, vehemently. One, you don't need to have documentation for most services. There are a couple of exceptions. There's an explicit regulation that talks about documentation for anesthesia. There's an explicit documentation that used to talk about teaching physician stuff, which we'll talk about in a bit. But generally, you don't need to have documentation. It's merely smart. And certainly, you don't need to redo documentation. You don't need 4 people writing the same thing. That's always been true. The problem, this is one of those that was created by people asking, hey, do we need to redocument? And so last year, we even got some new regulations that call into question that documentation guidance we've been giving. So CMS said, hey, there's no statutory or regulatory thing that would impact payment for therapists when documentation is added by someone other than the therapist. We're talking about it because people have asked. So this is the third reminder. Sometimes it's really better not to ask. I don't know why people think you need to redocument. It doesn't make a lot of sense. And my constant refrain is when you dictate, someone other than the medical professional puts stuff in the record, the doctor doesn't have to rewrite it after they dictate. That would be silly. Physical therapy assistance, historically, if you were doing maintenance therapy, it couldn't be billed by a PT or OT if an assistant did it. But during the public health emergency, if the PT or OT has established the maintenance program, that maintenance therapy can be provided. And I'm kicking myself in that last slide for not abbreviating MP and MT just so I could have a sentence with all abbreviations. All right, so let's talk briefly about the telehealth thing. It's such a big deal. We've already got a couple of questions about it. So it isn't in the rule, but it's allowed. We thought you could do it incident to. It's clear hospitals can bill for it. To just address a couple of the questions people have said, can critical access hospitals bill for it? Sure looks like it. Yes, I think the answer to that is yes. This was one of the changes. They are now making it clear hospitals can bill. If you listen to the the office hours calls that are on Tuesdays and Thursdays at 5 Eastern. I find that to be both educational and also remarkably validating, because it's becoming clearer and clearer to me that the people at CMS don't understand lots of the nuances, like what bills things go on. And I often struggle with this, right? Is this on a 1500 form, or is it on a UB, or what modifiers go there? And it is crystal clear that the policymakers have no idea how to answer those questions. So people are asking them, they don't know. And they don't know how to handle some of this, right? And so they're figuring it out, the details on how some of this is going to get billed, but hospitals can bill therapy. They can do telehealth. There are a couple of small changes to the Incident 2 rules. The biggest one is pharmacists can provide services Incident 2. Oh, crud. I did not put this on the slide. I believe that this is I believe this is only during the public health emergency, and maybe Katie can save me, but I don't expect you to because I'm supposed to know the answer to this. I think it's only during the public health emergency, and it doesn't continue past that. And COVID testing now can be done using a 99211 as a way of getting paid for sort of the protective equipment and the like, even if it's a new patient. So normally for a new patient, you'd have to use a 201, not a 211, but COVID testing for new patients can be done using a 211. All right, now Katie is going to do something really important. She's going to talk about all of the provider-based department stuff, which I find super confusing, and I'm glad she is here to be smarter than me.
I'm trying to save you on the pharmacist thing, and
I'll look while you do the.
Okay. All right. On to provider-based departments. So, the fact that hospitals are adjusting and shifting and repurposing clinical and non-clinical spaces to deal with COVID-19 has really called into question whether those hospitals that have provider-based departments that are accepted or grandfathered under the legislation from 2015 that protected their status, whether those protected or grandfathered sites remain protected even though, or grandfathered even though they're being moved around. And so just for a quick refresh, in legislation 4 or 5 years ago, CMS said that basically any off-campus provider-based departments that are established after November 2nd, 2015 are going to be paid at the physician fee schedule rate, which is a reduced rate. They're not going to be paid under the outpatient prospective payment system as a hospital anymore. So you got to pay attention, because if you add departments that are off campus after that date, that's fine, but you're not going to get paid under the OPPS. And so any departments before that were established before that are off campus are considered accepted. And then certainly on-campus departments are considered accepted and still paid under the OTPS. So to the extent we're moving these things around for COVID-19, what does that do? So at the time the legislation was passed and these new policies came out with respect to grandfathered sites, there was at that time a policy called the Extraordinary Circumstances Relocation Policy, which was sort of a needle in a haystack in my experience. CMS said, certainly there will be times when extraordinary circumstances warrant that a new off-campus department or a relocated off-campus department could still be reimbursed as a hospital under the OPPS. I had several situations where I thought extraordinary circumstances existed and CMS didn't agree. But with respect to COVID-19 and the public health emergency, CMS is basically broadly applying this extraordinary circumstances relocation policy on a temporary basis with respect to all of those provider-based departments that are being temporarily relocated. So basically, if you have an on-campus provider-based department or you have an off-campus provider-based department that was grandfathered or accepted, and you have to relocate those, because of COVID-19, to address COVID-19, you're still going to be considered accepted and paid under the OPPS, so long as doing that, relocating that department isn't inconsistent with some plan that your state may have developed. So this is a great example of a broad application of a policy, CMS being quite flexible and wanting to make sure people know they can move things around in order to deal with COVID-19. So there are some kind of tricky little, I guess not tricky, they're useful, but some things to know about this. How do you accomplish this? So there's not going to be a formal enrollment process or enrollment update that is required if you're relocating provider-based departments. So generally you would have to update your in PACOS or your 855 enrollment forms. You'd have to tell CMS through those formal processes that you're adding a provider-based department. You don't have to do that. You don't have to mess with PACOS. You don't have to mess with 855 forms, assuming that you're still billing everything out under the main hospital. You do have to provide a notification to the regional office, which I'll talk about in a bit, but you don't even have to provide that notification before you begin providing the services in these new locations. I believe this is, you could have been providing these services back to March 1st, and you didn't have to let CMS know about that. I do think I believe right before this webinar, I realized there's a 120-day notification requirement. So you do need to notify the regional office, which I'll talk about in a minute, within 120 days of beginning to provide those services in that relocated site, but you didn't have to do that beforehand. You would continue.
And Katie, I'm just chiming in for a second because you schooled me on something on this, which is when I read this, I interpreted the word location as being the place where the patient was. So if you were at the patient's home, you know, that's a location. And you corrected me. So how was I misunderstanding that?
So you have the location that you're talking about being relocated is the original provider-based department that was accepted. When you relocate it, the new location is going to be the new provider-based department location, which could be the patient's home, as we'll talk about. Does that help answer your question, David?
I think so, but because I was like reading, I kept reading location and thinking, oh wow, if you're doing this for 100 patients, you need to enroll 100 times, and
yeah,
that's
no, you
not
don't
right.
have to do that. And we're going to get to that. So you do need to continue to use the PO for modifier for OPPS claims if you're relocating a provider-based department, and you do need to tell the regional office of the relocation. So let's talk about what your notification looks like to the regional office. Got the next slide? All right. So
sorry, we're having some slide advancing issues there.
It's okay. Instead of having to go through this process of updating your 855, you need to send a notification to the regional office with this information. I know we're getting a lot of questions about the patient's home, and I'm definitely going to get to that. So the notification has to, you have to send an email. This is like CMS saying, make it easy, send us an email to your regional office. It should have your hospital, CCN, your certification number. It should have the addresses of the current and the relocated provider-based department. So the current as in the accepted site for the provider-based department that was in place prior to the pandemic, and then the new location of the provider-based department if you're moving it. Now, we're going to talk about in a minute how that can include the patient's home. So we'll come back to that. The start date of the services where you're providing the services at the new location. When did you start providing those services? This business about having to provide a brief justification for relocation and the role of the relocation in the hospital's response to COVID-19 and why the location is appropriate for outpatient services. That's sort of weird, ambiguous language. I think what CMS is saying is they want to know, what is your plan for COVID-19 with respect to these departments? Where are you moving them? Why are you moving them? Tell us how it works together. Don't make it long. Don't send us an essay. Don't ask us questions. Just tell us why it makes sense. And then tell them that you are not doing something inconsistent with what your state has told you. And that's all you need to do, is send that notification for any type of relocation you're doing, and you're good to go. So not only can you relocate a provider-based department that's accepted to a different location, off campus, on campus, in a parking lot, wherever, you can also relocate a provider-based department to a patient's home. In other words, you can provide outpatient services paid under the OPPS that would have otherwise been provided in the provider-based department. You could provide those in the patient's home and get paid under the OPPS. That's what CMS is saying here when they're talking about relocating a provider-based department to a patient's home. There are 3 buckets of services for which you can do this, and we'll go through that in detail. The key here is that if you anticipate, and I expect the vast majority of hospitals will do this, if you anticipate providing services in a patient's home and billing it under the OPPS, whether that's telehealth, which we'll talk about, or whether that's in-person services, you only have to tell CMS that you're going to do that once. You might plan to do that for 500 patients, but you need only tell CMS about 1 patient. So let's just say you have a provider-based department and you're going to move part of it to a parking lot for a testing site, and then you're also going to want to continue to provide services to patients in their home and bill all of it under the OPPS. How do you accomplish that? You need to send CMS an email with the things that we went through on the slide before, talking about why all of this is appropriate. And even if you're going to provide it to 500 patients, you only need to tell CMS about 1 patient. What I would do is say, here's our plan, here's our email, here are all the elements that I need to tell you about, and here is the address of David Glaser, patient, COVID lane, 123 COVID lane. And by the way, we're going to do this for everyone that otherwise meets the criteria for being an outpatient. And that's what I would do. I would send it off. And I think that meets what CMS is telling us you need to do. So it just keeps getting better. If you read this section of the rule, it's sort of amazing. It's like CMS is really just trying to be very flexible, which we appreciate. You may not, it may be that you want to entirely move your accepted provider-based department, like move the whole thing out. You can do that, and you can do it to multiple places. You can also say, look, we want to keep part of it where it is, but we also want to be able to expand it to all these other places, including the patient's home. So you can, CMS says you can relocate part of it and continue to bill where you were, as well as the other new places. This is a perfect example of where you need to heed the wisdom of CMS and say when they say that their non-specificity provides flexibility. So
we're going to see if we can get that slide to go. I don't know why. There we go.
I just have to make this comment. It's sort of interesting. CMS has this really broad set of, flexible language, and then they throw in this little comment about how they say we anticipate most multi-relocations or partial relocations would be to a limited number of locations. So they say go ahead and do whatever you want, move it out, move it partially out. But then maybe we expect that you're only going to do that to a limited number of locations. I don't know why they put that in there. I don't think you should make a big deal about it. I think you should do what you need to do and let them know about it and make sure it's not inconsistent with your state plan. One note here is that CMS does say in the final rule that you can't really, they don't expect that you're going to be changing sort of the nature of the department. So if you're moving an oncology clinic that's an accepted department to a place where it would typically not be grandfathered anymore, and you're doing it under this policy, that's fine, but we kind of expect you to still be providing the oncology services there. It's not like you're going to totally change the nature of what you're doing. So be aware of that, but again, don't get hung up on that. Don't start asking questions about specifically like the little services that you can provide. Just try to kind of keep it in the general theme as your previous department was. So getting back to what you can do in the patient's home under this temporary policy. So there are going to be 3 buckets of services that can be billed under the OPPS with the patient's home as the, quote, new provider-based department. Hospital outpatient therapy, education, and training services that could be furnished remotely. Hospital in-person clinical staff services that you can actually go to their home and deliver them. And then the technical portion of for telehealth services that's associated with the professional portion. So let's look at the first category here. The first chunk of services is really about CMS letting hospitals provide partial hospitalization program services with the patient at home. Now you can do these remotely. The individual psychotherapy, group psychotherapy, patient education, or you could do them in the home. But this is the first bucket. CMS has published a list of the permitted services under this bucket. The second group is services that are actually contemplated to have to be provided in person. And these are the in-person services that can be provided in the patient's home. They're going to be things like infusion services, wound care. Under this exception, you're not going to have to deal with the direct supervision requirement that would typically exist if you were in the hospital's 4 walls. So there are a limited number of services that can be provided in the patient's home that would have to be provided in person and can still be billed under the OPPS. Note that a lot of these types of services might overlap with what you would see a home health agency provide. And so you need to make sure that you're not overlapping those types of services. There has to be a temporal divide between the hospital services and then if that patient is getting home health, the home health service can't be there at the same time. And then, of course, you can't double dip or have that happen inadvertently. You need to make sure you're not overlapping with the patient's home health agency services. And then the final bucket is CMS. This has been a question that's been asked a million different ways, a million different times since the first interim final rule, where CMS said, look, if you're providing telehealth, you can bill as if the person was in person. If they typically would have been in person, you can bill that side of service. And everyone said, that's great, but what about the hospital facility fee? Doesn't the hospital get to bill their technical portion? Well, this is the way that CMS is allowing us to do it. Basically, during public health emergency, when the patient's home is considered a provider-based department, that at that time, assuming you've notified the regional office within that 120-day period, you can bill that telehealth technical portion and get paid under the OPPS.
Okay, we've done the heavy lifting. Thank you, Katie, for the heavy lifting. Now we're going to go through a whole bunch of things that will happen quickly. So first one, residency programs and medical education. So indirect medical expenses, or IME, or actually it's really education. There's a calculation that's based on the ratio between the number of residents you have and the number of beds. So if you increase the number of beds, you get paid less. CMS is saying we recognize that, so we're going to go back to the day before the public health emergency, which is January 30th, and we're going to fix your bed count at that date. So if you increase the number of beds, it's not going to lower your reimbursement. Similarly, if you're an inpatient rehab facility or an inpatient psychiatric facility, your status adjustment is also fixed to that date. If you have a residency program and you send your residents to another facility, either because you want them to help out there because of COVID, or you want them to get them out of your facility because of COVID, for any reason that is COVID related, the time spent at that other hospital will count. Normally it wouldn't. If someone leaves the approved site, normally time someplace else doesn't count. During the crisis, it will, as long as you sent them during COVID and it was an activity that would otherwise count, and the time that they spend immediately before and after the emergency are included in the base count. RHCs, rural health clinics. So if you're an RHC that is a integral subordinate part of a critical access hospital, you get paid an all-inclusive rate. And right now, if the bed count goes above 50, you lose the ability to do that. And CMS is saying that's silly during this emergency. You can increase the bed count and not screw that up. They're also making a staffing change to both RHCs and also federally qualified healthcare clinics. Right now, you need to have a nurse practitioner, physician assistant, or midwife available 50% of the time that the RHC is operating. That, and also FQHC, that's being waived. And so basically what this means is it's expanding the type of people who can be there. So it can be a social worker or a psychologist. And so we're expanding it. You still need someone there at all times, but we're broadening the length of things. By the way, I did go back and look on the pharmacy question. It does look like it is only during the emergency, but they didn't make it as a regulatory change, but it does look like that pharmacist incident 2 is only during the emergency. All right, let's have Katie, you want to talk about some care planning? Or am I talking about care planning?
No, I'm talking about it. I think you're talking about it in a little bit too. So the CARES Act was introduced a welcome change of allowing NPs, clinical nurse specialists, and physician assistants to order and certify patients for Medicare home health and to establish and review the home health plan of care. That is a permanent change, not just a public health emergency change, and this final rule made that really clear and also made it effective back to March 1st, 2020.
Teaching physician changes. So basically, the teaching physician world breaks into 2 buckets. One bucket is what's often called the primary care exception, and that was set up for things that were really clinics run by residents with a supervising physician that oversees up to 4 residents at a time. The residents were doing levels 1, 2, and 3, and it was really a functional clinic. And then there's sort of everything else, rounds and the like. This latest rule makes changes to those clinics, but not to the everything else. So the first interim rule said we'll let residents go up to a level 5. This one expands codes and lets you do things like the telephone visits, and basically all of the codes on this slide can now be done in those primary care accepted clinics. And when the resident is choosing his or her level of service, that can be on either medical decision making or time, just like they said in the last rule for other situations. But this is big. I've seen some emails that at least purport to be coming from the AAMC suggesting that supervision can be done via smartphone without the doctor being on the line when the resident is doing his or her thing. That is true in the primary care accepted clinics. That is not true during rounds. During rounds, the doctor has to be on the line, like physically present, but physically present counts via telehealth, right? It can be using an audio and visual connected device. But they got to be on that smartphone during the visit. And if you think this is a bummer, well, it does kind of suck. I took this picture when I was at the Sioux City Airport. They have the best airport acronym of all time. One of the other changes is to the audio telephone evaluations. And this is a huge change. And they did this, I got to give CMS credit. They solved the problem in a really smart way. So the problem was, old people don't always have smartphones. And give a shout out to Ron Hirsch here, who I monitored when I said, or his mother, who won't be on the visual component if she hasn't had her hair done. And as a hat wearer right now, I get that. So if you have a phone-only visit, you used different codes. You don't use the office visit codes, and they were paid squat. Now, what they did is they're not changing the codes. Codes are going to stay the same. You use the codes on the screen for a telephone-only visit, but they're going to get paid much like you'd get paid for a 99212, 3, or 4. So it's it's like a threefold increase in reimbursement. And the cool thing about this is that means if you've billed these, you don't have to rebill. Well, I should stand corrected. It's a little unclear if they're going to fix the payments back to March 1st. But if you've got them coded, you're set. You don't have to do any recoding. It's just there's a payment increase. So really smart solution. Do you have to resubmit claims you've already submitted to get the payment increase? I don't know the answer to that. I don't know that any of us know the answer to that. But great solution to a problem. Katie, I think you're up with lab.
All right. So the Families First Act, which was, I think, the second big piece of legislation, had added a new mandatory Medicaid benefit with respect to COVID-19 testing and lab and X-ray tests. So then the issue came up that the Medicaid benefit typically requires that those tests occur in the office. So this final rule removes the requirement that those tests be performed in the office, at least with respect to the lab. I don't know how you can do a home X-ray, but it makes clear that there's not a location requirement with respect to those tests, and then also permits coverage for self-collected lab test systems if and when we get those.
Katie,
and then that, yes.
Okay, you finish this. I'm gonna correct something. So go on.
Oh, that's going to be during the public health emergency and then any other period of active surveillance. So I think they're anticipating that there may, the emergency may be over, but there may be times following it that they need to make sure that these tests are covered.
So I just want to go back because I screwed up one thing I wanted to mention on the last slide. So actually 2 quick points. One, remember, so a 21-minute telephone call now is going to pay you the same as a 99214. So, so that I just want to note that. But here's a tip. I would encourage you to call a local reporter and try to get them to do a story about telehealth, because I think a lot of people don't know that people are avoiding medically necessary visits, and you guys are all hurting because of it, and it's driving you nuts. I think this is an easy thing to get a reporter to do a story about, because it's helping the people who watch the news, right? You've got a bunch of seniors who are watching the news. Call each of the stations and get them to do a story about how they can see the doctor without leaving the home, because people don't understand that. You can, if you're waiving copays, you can even explain that as part of the story. Remember, on telehealth, you have the option. You don't have to, but you can waive the copay. So this is a way, and by doing it with the news, you can do it for free, right, as opposed to sending a big mass mailing to help the bottom line. All right, sorry about that, Katie. That was my screw up.
And then I think this one is you, David.
Oh, this one's me. So that's another screw up. Okay, Medicaid home health services. The CARES Act expanded who can order home health. It allowed nurse practitioners and physician assistants to order home health. And now they're syncing that up to say that's going to be true for Medicaid too. This is not limited to the public health emergency. It's broader. There's some weird discussion about how non-physician practitioners can order DME, but what they really mean are supplies. I didn't follow the discussion. I think they really mean stuff, not durable medical equipment. And no longer does the non-physician practitioner have to report to the physician. They made some changes to NCDs and LCDs, and they talk about how there are a bunch of there's a statement in there that talks about how LCDs are critical conditions a patient has to meet to qualify for coverage of a service. That statement is wrong, as we'll talk about in a moment, but the real reason for the discussion here was to just highlight some people are misunderstanding the waiver that's given for NCDs and LCDs. They are not trying to say that all medical necessity requirements are gone. Instead, they are saying that on the list of NCDs and LCDs that we listed in our last webinar, coverage is not limited to the specific listed diagnoses. If it wasn't generally medically necessary, then it still isn't going to be covered. And I just want to mention this is a little off topic, but it's on this LCD thing, and it's correcting the error in the CMS statement that an LCD is a critical condition for coverage. The AseraCare case, which is an 11th Circuit case, had the Court of Appeals saying that LCDs are not binding and they shouldn't be considered the exact criteria for determining an illness. You do not have to follow an LCD. So that's unrelated to the public health emergency, but an important thing to remember. Katie. Oh, is this me too?
This is you.
All right. I've just got to pay more attention to this. So I should know this because I love saying IRF-PI so much. I've always thought about IRF-PIs. So basically, there were certain reporting requirements involving the data set and SPADES that were supposed to go into effect. They are being delayed, and basically they're being delayed until the easiest way to say it is the second October 1st following the public health emergency. So the first full fiscal year that there is no public health emergency. So the earliest it could happen would be October 1, 2021. And if the public health emergency goes on, it'll fall accordingly. All right, this time I know it really, truly is you.
All right, this is quick too. Basically, CMS said that they're going to cover antibody tests, and that's just that are FDA authorized antibody tests, and that's just going to be the situation. There's not going to be an NCD for it. Usually they do NCDs when there's new coverage determinations, but they're moving on, and they're going to apparently amend 41032 to reflect that. And much anticipated part of this rule was the set of requirements with respect to long-term care facilities that now need to report COVID-19 related statistics to CMS and the CDC, and also to the residents and their representatives and families. So this was foreshadowed, and this final rule specifies all of those requirements. Basically saying that long-term care facilities, nursing facilities, skilled nursing facilities are going to need to report in a format that's going to be developed by CMS, some sort of standardized reporting format. A number of things, including confirmed and suspected infections among residents and staff, total deaths among residents and staff, PPE and hand hygiene supplies, and sort of status of how much there is in the facility, ventilator capacity, resident beds and census, access to, it's a typo, COVID-19 testing, staffing shortages, and anything else that's going to be on that standardized form. I will note, I think this slide is a little bit different than what was sent out previously. It has more detail. So in the final set of slides, you will see this updated version. It's also now the case that the long-term care facilities are going to need to report to the CDC, the same information to the CDC at least weekly and maybe more often. So look for CMS's standardized reporting forms as they come out. And now it's 1 o'clock on the first Wednesday of the month in the Twin Cities, so our tornado drill sirens are going off. So if you can hear that.
It's just a reminder that we're going a little over time, and we apologize for that, but it's free, right? So if you need to sign off, you can always, if you want to catch the end, you can.
Right.
But yeah.
Go ahead, David.
No, go ahead.
So the other part of the reporting requirements for long-term care facilities are not just reporting to the government, but this is probably a bigger deal to people, is that they have to inform residents the representatives and families of people who are in the facilities daily by 5 p.m. the next day if there's been a single confirmed infection of a resident or a staff member, or there have been 3 or more folks, residents or staff, with new onset symptoms that have occurred within 72 hours of each other. So this is going to give residents and their families more up-to-date information. You don't have to do this by calling each person individually. You can do it by newsletter, email, website, portal. There's flexibility around how this report goes out to residents and their families. And you're not supposed to be including PHI. And you're also supposed to be telling those folks what it is you're doing to mitigate the infection, and then whether there are going to be any restrictions on group activities or visitors.
All right, I'm going to skip the joke because we're running late, but I don't think that this is happening very much right now. Not a lot of sneaking around, although the extra needs to get meat is kind of, so don't line up at the grocery store. All right, so time for choosing the E&M. This is merely a clarification. This is what I would have said before, but CMS is just going on record to say you can use the CPT typical time. There are different times listed in different sources. Like there's a public use file, and it has radically different times than the CPT. You can use the CPT times for when you're using a time-based code. This is really guidance that applies only in the clinic and outpatient hospital setting. It's still true for inpatient E&M when you use time. I wasn't clear on the slide here, but the difference is, remember, you can use medical decision-making or time now for clinic visits, but if you're doing rounds in the hospital, you still code the traditional way. That's going to be extra confusing. There's an updated telehealth list. So we talked before about telephone visits. Remember, the difference between telephone is audio only, telehealth, audio and visual. So there's an updated telehealth list, and CMS is allowing more and more services to be provided via telehealth, and they're even kind of hinting that that list that's going to appear on the website is illustrative, not exhaustive. So that means if something isn't on the list, it might still be covered. So that's, talk about generous. All right, remote physiologic monitoring. And this is an interesting one. We got a really astute email from a listener, an attendee on this. So remote physiologic monitoring codes generally require that you do at least 16 days of a 30-day period for monitoring. And recognizing that some COVID patients will have less monitoring time, CMS is saying they will allow you to use those codes as long as you have at least 2 days of monitoring for a patient who has either a confirmed or a suspected case of COVID. So the question, and I don't know the answer to this question, but the question someone sent us was, well, why is the add-on code billable but the primary code not billable? And that is, as Winston Churchill would say, a mystery surround an enigma, a riddle wrapped in a mystery sounded an enigma, or whatever the heck he said. Speaking of mysteries and enigmas, you want to talk about the QAPI program?
Sure. So now we've moved from the interim final rule changes to some updates to the waivers that have occurred. And I say that because you're not going to see this stuff in the interim final rule. You're going to see it on the updated documents on CMS's website with little blurbs about each type of provider. The SNF, apparently, QAPI program requirements are going to be narrowed to really only require them to focus on infection control related to COVID-19 and reporting adverse events. I don't know what that revised language looks like because it's not like it was published in a final rule, which is sort of the odd thing we were talking about at the beginning. But be aware that there's some flexibility there, and I wouldn't spend a ton of time focusing QAPI stuff on anything other than COVID-19. Some other changes for SNFs and nursing facilities, basically that requirement to give nursing assistants 12 hours of in-service training has been postponed until we get to the first full quarter after the public health emergency is concluded. And then again, another waiver or postponement for long-term care facilities is basically all that discharge planning processes and requirements about giving information with respect to assessments and quality measures and other data like that is going to be, those particular requirements are waived during the public health emergency to facilitate faster discharge planning. Couple sets of changes for home health agencies, and then next we'll get to some hospice changes. The 12-hour annual service training requirement for home health aides is going to be postponed until the end of that first full quarter following the public health emergency. The detailed discharge planning requirements are waived, and then the CMS is giving home health agencies more flexibility in terms of the timing for producing copies of medical records, so going from 4 days to 10 days. The annual on-site supervisory visit that's required for anyone who's a home health aide is going to be waived until a couple months, 60 days past the public health emergency. Similar to skilled nursing facilities, the QAPI program requirements is really narrowed to be requiring only focus on infection control and reporting adverse events. And then for hospice, the annual assessment for those who are providing hospice services is waived until that first full quarter following the public health emergency.
So ASCs, this is an easy one. They don't have to reappraise the medical staff annually during this public health emergency. So basically, if your privileges expire, people can continue. That's the shortest slide you'll ever hear me do.
And then really quickly for community mental health centers, the QAPI, same theme with respect to the QAPI programs. They can focus more on COVID-19 related matters without the other requirements during this time. They can also be providing partial hospitalization program services in the patient's home. And then that requirement that a community mental health center have at least 40% of their items and services provided to people who aren't Medicare beneficiaries, that's waived because they're anticipating more Medicare folks will be needing the services. So the CMHCs don't need to worry about that requirement.
So we ended our last webinar, and we're going to do the questions now, but we ended the last one with a rainbow out of the Minneapolis office and me saying, someday we'll be back there. I've been lucky enough to give a speech in Hawaii for like a dozen years, and oh man, I want to be able to do that again next year. Don't know if it'll happen or not, but if I'm focusing on the rainbow because we're going to get through this. All right, we got a boatload of questions, and we don't have too much longer to do them, but we'll try to work our way through them here.
I can take a couple of questions here, David, related to the off-campus provider-based department relocation.
Go for it, Katie.
That I think are really good ones, and I didn't mention one of them. So if you read the final rule, you saw some discussion about how off-campus departments that are relocated have to still meet the hospital conditions of participation that happen to still be in effect. And there's not a lot of detail about this in the final rule, which signals to me that I don't think CMS is too hung up on it. So some folks have said, what does that mean? How in the world are we supposed to meet the conditions of participation in a patient's home, for example? Well, it happens to be the case that most of the conditions of participation that you would be worrying about meeting that would maybe still apply to a patient's home have been waived. So when I think about the COPs that are probably easy to meet, or that you wouldn't have to worry about whether you're in the patient's home or in the hospital, governing body, patient's rights, those sorts of things, I wouldn't worry about those because they're not hard to meet. A lot of the requirements aren't going to be applicable to a patient's home: pharmacy services, lab services, radiology services. You still have all that stuff in the hospital. And then the things that are a little more interesting or would maybe be difficult to meet in the patient's home have largely been waived. So that physical environment standard, it's waived. Don't have to worry about life safety code in the patient's home. Don't have to worry about building safety. Utilization review has been waived to a certain extent. Discharge planning, that doesn't even really apply, but that's been, large parts of that have been waived. Emergency preparedness, a lot of that has been waived. QAPI can be focused on COVID-19, so there's been a partial waiver there. Nursing services, you typically have to have an RN present at every location in the hospital. That's been waived. So what I'm left with when I think about this question is really what is hard to meet in the patient's home that hasn't been waived, and that's really infection control. And so I think if I was going to spend a little bit of time but not too much thinking about COPs in the patient's home, I would make sure that there's a good plan for people who are providing in-person services to make sure we still care about infection control and are doing it in a, in a safe and effective way. And I think about that and try to make it that way, and then I'd move on, because I don't think this is a huge obstacle.
So, Kate, that infection control leads really well into a question from Katie. So our laboratory interpreted, and so this, people who are still on, you're going to want to stick for this one because we're going to cover something everyone's struggling with. So our laboratory interpreted CMS's statement that laboratory tests for COVID-19 would not require any provider signature at all. Is that correct? Or does it just not have to be the patient's regular treating provider? And so they're focusing on Medicare won't require an order from a treating physician or non-physician practitioner as a conditioner of coverage. So what's really important here is understand the difference between an order and a signature, and then understand what we want to do with signatures during the COVID emergency. So Katie and I did a webinar some time ago on orders and signatures, and it's worth going back to try to find that thing. But most orders do not need to be in writing. And my source for that is the Federal Register from October 31st, 1997, where when IDTFs were created, CMS said IDTFs need to have written orders, but that's unusual, okay? Now, to be clear, people often think you need a written order, but often you do not need a written order. An oral order is sufficient. Signature is a different critter. And I think I would say, as an infection control matter, I'm not going to make anyone sign anything right now. And that's a fight I'll have. If someone wants to come in and say, this wasn't signed, I would feel comfortable defending you and saying, life is full of risks, right? There's the risk you get in trouble for not having something signed, and you have to balance that against the infection control risks of having someone taking a pen and signing stuff. And I would universally say blow off signatures. There are places CMS has made that very clear. You can, for example, get consent on telehealth from the patient by recording the person making the call talks to the patient and records what the patient said. That's one way. But signatures are generally not going to be required. And here, I think actually the order, as Katie explained, you don't need an order from the treating physician. So that's a different thing than a signature. Okay, that was a long-winded,
yeah, but no, that's a good point, David. And I think the order, you still need an order. And the question is, who in the heck is making the order, right? And especially if I want to go drive up testing, and I've never seen anyone in that system before, who's ordering it? Well, I think you could look into whether you have a standing order. Maybe you have a really broad standing order that's made by your CMO or something like that. I don't think CMS is going to be in the business of trying to exclude COVID testing when there was a reason to get the test done. Now, they might not be interested in paying for someone to get a test every week, but I think you could probably deal with that issue by making sure people don't get a test every week, unless they need one. But, not everyone needs a test every week. The other, we did get a couple comments on, at least questions or comments on whether this weirdo question about whether you have to provide CMS with every patient's address when you're expanding the provider-based department to the patient's home. So again, I would say, first, you're not going to be worried about expanding to the patient's home unless you're trying to preserve your off-campus status. And I understand that's probably still a lot, but I just want to make clear that if you're doing this for a non-grandfathered place, I don't think you have to worry too much about letting CMS know. This is really about preserving that enhanced payment into the OPPS. When I read the final rule, it is not, I think CMS is saying you only need to do this once. You need to submit one unique patient. Someone said they thought that they heard from someone else that CMS said in the call yesterday that you have to submit every patient's address. I don't think that's clear in the final rule, and I really can't imagine that CMS wants 10 million emails with people's addresses every day. But we'll, if that comes out and changes, we'll certainly let people know.
Well, and I want to just chime in. The reason Katie's suggestion is so brilliant, too, is when you tell them what you're doing, like, if you think about it and take a step back, how much trouble are you going to get in when you've told the government this is what we're doing, right? It's hard for anyone to get really indignant, especially if what you told them then makes so much sense. So if you go that route, how much can someone yell at you? The answer is not that much. So Katie, this one, can a hospital-based congestive heart failure clinic or pulmonary rehab clinic provide and bill for services provided to patients who are at home? And then if the answer to that is yes, does the provider have to be an APN, or who else can do it?
So you would want to look at the codes you're seeking to provide at home and figure out if they're among those three groups of things that can be provided at home. Remember, the three groups were mostly PHP services. So it doesn't quite seem like what you're talking about. There are some in-person services that can be provided, but there's going to be a list of those. It's going to be things like infusions, might include some PR and cardiac rehab. You just need to look at that, or you have to look at the telehealth codes and see if they fall under there. So it's not going to be the case that you can move all outpatient services to patients' homes.
So there's a question here. If you've got a patient who's maybe a pediatric patient, or in this was an Alzheimer's or demented patient, and the patient isn't present during the visit, what happens? And I would treat it the same way you would basically view telehealth as like the office, right? And just as you can have visits sometimes with family members that count, same thing here. For rehab, is the standard that PT and OT, can we bill for them on a UB? And I think the answer to that is yes. Basically now, if you do telehealth from your hospital, you'd bill it. It was really clear that the people from CMS, they just kept saying bill it the same way you would as if they were in the place. They weren't clear on the specifics and the nuances there. I know you've got to go in a second, Katie, and so do I. You see any others you want to grab before we depart? And we have a lot of questions. I'm afraid we're not going to get them all, I don't think.
Yeah, it looks like we got some questions about the regional. Who should send the email to the regional office? Does it require a specific person or role? This is for accepted off-campus providers departments. No, there's no requirement about who sends it. I say send it, keep a copy, and you've met the requirement.
Let's see. There are a whole bunch here. So here's so are there legal issues with excluding COVID patients from the process of sending accounts to bad debt or collections if they're not paid? Could we be at risk of treating one set of patients differently from another? Now, I am not a collections expert, but I guess my first observation, and I'm going to look for Katie's guidance here too, is that you are more likely to get in trouble for accident. If you put some of these folks into collection, that can raise issues, because in a lot of states, and there's basically a bunch of laws right now that are going to limit your ability to collect on COVID debt. So I would be more worried about inadvertently collecting than from not collecting. So, and it is generally legal to treat people differently unless you're doing it for an illegal reason. And there certainly wouldn't be an illegal thing going on here. So if you said we're not going to put COVID people in collection, you won't get in legal trouble for that. And I look to Katie to see if you disagree.
I think that's right. I agree with you, David.
Have you seen the rates for the 99441 to 43? And I've just seen what's in the press release. So, all right, we're coming up here on a time we should probably scamper off. we are inundated with enough questions right now that I can't say we will promise to answer them all offline. We'll see what we can do, but if we don't get to yours, I apologize. I hope that next week you will tune in for healthcare pricing. We don't know what's going to happen in June yet. Like we should have a pool to see if May 30th is going to have, COVID interim rule part 3. And we'll see then what our June webinar is.
Then maybe we could do trilogies. What's the best trilogy?
If there's ever been the third movie better than the first 2, I can't name it.
I think in the minority that like the episode 6 or 3rd of the original Star Wars better than the first 2, but no one else seems to agree with me.
But you didn't like Return to the Jedi more than than Empire Strikes Back, right?
I did. I liked it more.
Oh wow. Okay. Yeah. All right. I usually agree
Yeah,
with you on pretty much everything, but on this one, I don't think I can get there.
I liked it.
I don't know. I don't know if there was like but like Ghostbusters. Ghostbusters 1 made me laugh. Ghostbusters 2. Okay. So we're it's getting bad when we're making lots of movie references. I just want to thank you guys all for putting up with us and my bad jokes. Katie's jokes are more respectful.
My 6-year-old, the tornado sirens, all of the things.
So thank you so much, and stay safe and stay sane.
Bye.